You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 22nd, 2024. We are doing our orientation series, and today we will be discussing diagnostic tests for allergy. This is presented by Dr. J. Portnoy, who is a professor of pediatrics, and Dr. Pandya, who is an assistant professor of pediatrics in the Division of Allergy, Immunology, Pulmonary, and Sleep Medicine at Children's Mercy Hospital.
Welcome to Conference Online Allergy. We have two talks today. The first one is on diagnostic test for allergy, which is an important part of what we allergists do. And then the second part, we'll be talking about what you do with the information you get from the diagnostic test, which is develop and administer allergy immunotherapy, which is really strongly dependent on us doing a good job of diagnosing what the patient is allergic to. So let's move forward. These are our disclosures. The only one I have is Thermo Fisher. They do make diagnostic tests. They're not paying me for this presentation. These are the learning objectives. And I usually like to start out with some scenarios and just ask you to kind of think in your mind what you would do in this case. The 9-month-old has a positive blood test for egg allergy. She's never eaten egg. What would you recommend? This is a very common scenario. Somebody does a blood test is positive, they don't know what to do with that, they send the patient to you, the parents are afraid to introduce egg into the patient's diet, they want your advice. What should you tell them to do? And that becomes a real problem. It would have been so much better had the test not been done. You would have just advised them to introduce egg. Now that the test has been done, the parents are nervous. What do you do? It's a real conundrum. These are the types of things that we're going to be addressing at this conference today. And I don't have an answer for you. Each of us, if you polled the audience, you'd probably find that each of us have a different approach to this scenario. A 5-year-old with a negative blood test for peanut IgE, but had anaphylaxis after eating peanut butter 4 weeks ago. This seems pretty clear. The blood test is negative. And yet the patient had anaphylaxis with peanut butter. We can presume, since the connection was so clear and the reaction so severe, that the patient is allergic to peanut butter, whether we can detect specific IgE or not. I think in this case I would tell parents to avoid peanut butter and carry an epinephrine autoinjector, consider desensitization or omalizumab. Even though the test is negative. You can't give omalizumab for this one, by the way, because if the peanut IgE is negative, you can't justify it because it's based on IgE. An 11-year-old with eczema has a highly positive skin test for peanut. He eats peanut butter every day and he loves it. Why was the test done for peanut if he eats it every day and loves it? That would be my first question. My second question is, why wouldn't he just keep eating it? He loves it. He's not allergic to it, even though he has eczema. So in this case, it's very clear. Patients should just keep eating peanut butter and ignore the test. The 9-month-old has perennial rhinitis and a positive test to dust mite and ragweed. Well, if the patient was born in, let's say, October, they've never seen ragweed, a positive test to ragweed couldn't possibly mean anything. It's not really clear what you're going to do with this information. They have perennial rhinitis. Maybe dust mite avoidance would help. It's not clear. Certainly perennial rhinitis wouldn't be caused by ragweed. Ragweed's only present in the air for 6 to 8 weeks at a time. So again, what do you do with this? So it's very questionable, and these are some other questions that sort of get at a different aspect of it, and that is, given the same information and the same probability, you would tend to do different things depending on the patient. So 9-month-old has a 4%. Let's say you did the testing and you did the challenge and all that, and you've determined that there's a 4% probability of a systemic reaction if they eat peanuts. Somehow we just know that. What do we recommend? Most parents are very nervous about giving 4% probability in a 9-month-old. They're very little. You're worried about it. Most parents would want to avoid it, even though there's a 96% probability there'd be no reaction. 4-year-old, It's a little bit less clear because in a 4-year-old, if there's only a 4% probability of a systemic reaction after eating peanut, first of all, you don't know what kind of systemic reaction. The second of all, the patient's probably going to be exposed to peanut anyway, and they probably really want to try eating peanut. So then there's not quite as much anxiety about exposing them to it. And then the 16-year-old, he's a tough person. He's going to just try eating the peanut and see what happens. That's not even a problem with that. And if the parents say he can't eat it, he's going to go out of the house and eat it. So he's going to do what he wants. Now, the problem here is that the probability of a reaction after eating peanut is widespread and ubiquitous. It's very likely there's going to be exposure to peanut. So it's important to know whether this is a real probability and what would happen if the patient eats peanut. 4% probability of a reaction after a bee sting is a little bit different because you're very unlikely to get stung by a bee. Bees aren't that common anymore, and so you have to consider not only the patient and how sensitive they are and how worried we are that they might have a reaction, but also how likely it is that they're going to be exposed to the thing that's going to trigger the reaction. Those are all considerations that have to be taken into account when we do diagnostic testing. So I'd like to start with this sample of 1,000 allergy patients. Picture 1,000 allergy patients. Suppose that 1% of them have peanut allergy. Okay, it's the prevalence in our population is 1.5%, but for math, the simplicity of doing the math, 1% of them have peanut allergy. Okay, what does that mean? Well, 1% of 1,000 is 10, so 10 people have peanut allergy. If the test is 90% sensitive, then 9 of those patients will be detected by the test, and 1 of them will not be. So there's a false negative. So there's 9 true positives, and there's 1 false negative. On the other hand, 99% of these people do not have peanut allergy. If the test is 91% specific, that means that 901 of these patients who don't have peanut allergy will correctly have a negative test. But unfortunately, 89 of them will have a positive test, even though they don't have peanut allergy. We call those false positives. So that's the concept between true and false positives, false negatives, and true negatives. You can get these things. So here's the question that could be on your board exam. I don't know if it is or not. It's been long enough since I was on the boards. I haven't written any questions in a while, so I don't know if this question's on it, but if it's not, it should be. How many patients with a positive test for peanut allergy actually have peanut allergy? If the test is 90% sensitive and 91% specific. Is it 90%, 80, 10%, or 1%? Kind of think in your mind what you think it might be. And these characteristics, sensitive and specific, for this test, those are really good performance characteristics for any diagnostic test. And most people would be inclined to think maybe 90% because, it's pretty likely. And yet that's not true. Remember, the patient has a positive test for peanut. The patient is either one of the 9 true positives or one of the 89 false positives. So the probability of having a peanut allergy, given that the little vertical bar is given that, the test is positive, is approximately 9 divided by 9 plus 89, or 1 over 11. That's the positive predictive value, which is total positives over the true positives plus false positives. So it's 1 over 11 is the probability. So the correct answer is actually close to 1 in 10. It's actually 1 in 9. That's the closest answer. Even though 9 in 10 seems true, 1 in 10 is the actual answer. And so you can do the math shown above, and this is something that I would suggest that you become familiar with. The reason that the highly sensitive and specific test is giving you this misleading information is because the prevalence is so low in the population. If the prevalence was similar to the population that the test was designed for, then there would be a closer concordance. Okay, so that's an introduction, and it just shows that we can we tend to misinterpret the results of tests. The fact is, most tests are dichotomous. There's usually a positive and a negative with the cutoff. I really hate dichotomous tests, but they're very easy to design and to interpret. The reference test is the gold standard. That's the test that defines the condition being diagnosed. The index test is the test that's being used as a proxy for the reference test. So why wouldn't you just do the reference test? It's the gold standard after all. You would use an index test mainly because they're usually less expensive, they're easier, quicker to perform, they're readily available, and they're often safer to do. For food allergy, the gold standard is an oral challenge where the patient might have anaphylaxis. It takes a long time to do, it's expensive, there's a risk involved. If you do a blood test, which is a proxy for the oral challenge, it meets all of the criteria listed here. And we list these things out in this thing called a confusion matrix. It's not called that because it's trying to confuse you. It's trying to actually reduce the confusion between patients who have disease and patients who don't have disease. Basically, it lists the reference test along the top and the index test along the side. And you get the true positives, true negatives, false positives, and false negatives. And then you can calculate all of these parameters from this confusion matrix. This is something that if you're going to take allergy boards, you might want to commit to memory some of the aspects of this, or at least be able to reproduce them, because questions like this may show up on the boards. I don't know for sure. Like I said, I haven't taken the boards in a long time, but it's possible. So here's what we call the frequentist approach. There's two approaches to diagnostic testing. There's the frequentist approach and the Bayesian approach. The frequentist approach would say that a 4-year-old suspected of having peanut allergy has a specific IgE of 10.3 and no history of ingestion. You wonder, why did they do the specific IgE if the patient didn't eat peanut, but it happens all the time and you're going to have to deal with it. The question is, how likely is it that he'll have a systemic reaction if he eats peanut? So then we have the cutoff of 0.35 for the test. So this is a confusion matrix designed by the Bayer study. Basically it shows the number of patients who actually, how many patients actually have peanut allergy and how many patients don't have peanut allergy. And then it shows how many tested positive and how many tested negative. And the accuracy is a combination of all of them, and it's just how accurate, how often does it correctly categorize it. It's 80% accurate, 86% sensitive and specific, positive predictive value 82 and 89. These are all pretty reasonably high values, so this is a reasonably good test. 82% of the patients with a positive test had peanut allergy. You could conclude, therefore, that the likelihood that your patient will have a reaction is 82%, and that's incorrect. Why is that incorrect? Well, let's look at how the Bayesian approach works. Basically, we have a disease that we're trying to diagnose, and we're trying to determine the probability that the patient has the disease. We're not trying to say yes or no. We're trying to get a probability, because that's how we operate in the Bayesian world. If we don't know anything about the patient, then the prevalence of the disease in the population is called the prior, and that's the probability of disease. That's your best estimate of the probability the patient has the disease, the prevalence. If you want more information, you can ask the patient a history. Did you eat the food? Did you have a reaction? Did you not have a reaction? If they say, I had a reaction, then the probability that the patient has the disease increases. That's called the posterior, and that's the disease probability after the test is done, the post-test probability. And that may be enough information for you to recommend avoidance. If they had anaphylaxis after eating peanut, you might just stop there and do avoidance measures. Sometimes the history is not clear and you're not really sure, so you want to do another test. You could do an allergy test. And in this case, if the test is positive, it increases your estimate of the disease probability. If the test were negative, then your estimate of the disease probability would decrease. So you can see that by doing sequential tests, and these have to be independent tests, you can get an estimate of the patient's probability of having the disease. The thing is that allergy tests are not the way to make a diagnosis. Although I suppose if the test is the reference test, it defines the diagnosis, so then that's a special case. But if you think about it, the diagnosis is not really what we need to treat the patient anyway. Just because I call it peanut allergy doesn't really tell me what to do about it. What we want to know is what treatment is most likely to help. A test provides evidence that modifies either up or down the odds that the diagnosis is present. Once we have those odds, we have to then decide what to do with them, what treatment is likely to be effective. So here's the Bayesian approach. You determine the pretest odds, the prior. That can be based on the history of reaction or the prevalence if there's no history. You can test for specific IgE to get a likelihood ratio. It can either be a skin test or a blood test. And that helps you to determine the post-test odds, the probability of being allergic to an allergen given the test results. Then you have to decide what to do about it. And these are the things that you could do. You could do targeted environmental control and allergy shots for aeroallergens. You could avoid the food, carry epinephrine, and consider oral immunotherapy for foods. And now you could give omalizumab too. You don't worry about, or the other option is don't worry about aeroallergens and go ahead and eat the food if you want to. That's what you do if the test is low enough. So it's either high enough or low enough. If it's in the middle and you're not really sure, you may need to do another test. I mentioned that there are these cutoffs. The frequentist approach usually relies on cutoffs to categorize a test as positive or negative. And yet I question this. Does a peanut IgE of 0.36, which is above the 0.35 cutoff, really imply the same risk of a reaction as a peanut IgE greater than 100? It seems, logically, intuitively, that couldn't possibly be the case, and yet we're treating them as the same. So having a yes-no cutoff really loses a lot of information by categorizing it. Bayesians also use cutoffs in the form of LR plus and LR likelihood ratio for a positive test, likelihood ratio for a negative test, but it's really better if you use the likelihood ratio for each value of the test. That's a continuous thing and it doesn't rely on a cutoff. Okay, so here, this is what I'm talking about. This is a slide that you see all the time. The higher the IgE, the greater the risk for symptomatic allergy. The logistic regression can help classify the results of a continuous variable. So if the IgE is low, then the probability of a reaction is low. If the IgE is high, then the probability of the reaction is high. The problem is it doesn't take into account the pretest probability, whether the patient had anaphylaxis or not beforehand. So if the patient had anaphylaxis and their IgE is low, we call that a false negative. It's not a false negative. The test is what it is. It's giving you the information it can give you. The problem is you're not using the test to the best benefit. What you need is something called a likelihood ratio. The likelihood ratio is really just the slope of the ROC curve, and it's basically how much more or less likely it is that the patient has the disease given the test results. And I'll define that on the next slide. But you can see that you can define a likelihood ratio for each value of peanut-specific IgE. So the higher the IgE, the higher the likelihood ratio. And by doing linear regression, you can use your electronic medical record to get an accurate prediction of the probability that the patient is allergic to the peanut, for example. And you can do the same thing for egg. There are some likelihood ratios for eggs and some ROC curves for eggs. And so what is a likelihood ratio? The likelihood ratio is just how much the test result changes your estimate of the probability that the patient has the disease. Most people show the Fagan nomogram on the left, which I think is really complex and tedious and unusable. I prefer the McGee heuristic. It's on the right side. And basically what McGee said is if you have a likelihood ratio of 1, how much change does that give in your estimated probability of the disease? It doesn't change it at all. A likelihood ratio of 1 means no change in the disease estimate based on the test results. If you have a test that gives a likelihood ratio of 0.1, that means that the estimate of the probability of disease decreases by 45%, which is a huge decrease. It makes it much less likely that the patient has the disease. If the likelihood ratio is 10, then the patient is 45% more likely to have the disease. And all of the various values in between, and you can interpolate between these specific values if you want to. I think this heuristic is very easy to apply to my patients. I don't have to take rulers, and I don't have to do all of the calculations. Let's do some calculations. We do have spreadsheets after all. So here's the Bayesian approach. 4-year-old peanut allergy, specific IgE 10.3. How likely is it that the patient will have a systemic reaction? Well, we start with the prior belief or credence, which is the prevalence in the population, which is 1.5% for peanut. This will be different if you have a history of prior ingestion, then you change your probability based on that history. The odds, you have to convert it to odds, the probability of having the disease over the probability of not having the disease, which is 1.5 over 98.5. And then you have to update your prior belief once you have new information. So for our patient, it's unclear or no history of peanut reaction. The pretest probability is 1.5. Peanut IgE of 10.3 is associated with the likelihood ratio of 6.1, and that's from the Bayer study that we showed earlier. So 6.1 is an increased likelihood ratio. So you can see that the probability of 1.5% is equal to a pretest odds of 0.015. Multiply that times the likelihood ratio, and you get the post-test odds of 0.091, which is equal to a probability of 8.4%. Post-test probability of a reaction, 8.4%, is pretty close to what the actual value is versus the 82% we got from the positive predictive value. So you can see how if you take into account the pretest probability, you get a much better estimate of the actual probability that the patient is allergic than if you just use positive predictive value, because it takes into account the prevalence in the population. Well, maybe that's enough information and maybe it's not. I recommend doing something called a reflex test. If you do an initial test and it meets its predetermined criteria, then you can do additional tests. It avoids unnecessary tests to reduce costs, and most labs will offer them. So, for example, if you have a cat IgE less than 0.35, it stops. If it's greater than 0.35, then you might have it measure cat components automatically. You don't really want to do cat components if the cat's negative, because they're all going to be negative too. So it's more cost effective to only do it if the cat IgE is elevated. You can do the same thing for peanut or for anything else. So that's what's the advantage of a reflex test. In the case of peanut, our peanut IgE was 10.3. Since it's greater than 0.35, we do measure components. And here's the results of the components for our patient, measuring error H1 through 9. And you can see that the error H2, which is the most predictive value, is 5.23, which is elevated. So what do we do with that? Well, an error H2 of 5.23 is associated with the likelihood ratio of 25 based on another study by Nicolo. They measured that. And so if we start with our probability of 8.4% and we multiply the pretest odds by the likelihood ratio of 25, we get a post-test odds of 2.3, which is equal to a probability of 69, almost 70% probability. That's a very high probability of having a systemic reaction. Our decision is to avoid peanut, carry epinephrine, and retest at appropriate intervals, maybe OIT. So that's the advantage of using the Bayesian approach. Now, nobody's going to sit here and do the math, but this math can be built into our electronic medical records and used as decision support. Where do we get these likelihood ratios? Are they available? Well, here's one from Gendo. He looked at allergic rhinitis, and he looked at the likelihood ratios for the history. If you ask the patient, does pollen cause symptoms? And they say yes, then the likelihood ratio is 2.5, which means that the probability goes up. If they say no, pollen does not cause symptoms, it goes down. So you can use these to modify your estimate of the risk that the patient has allergic rhinitis. I noticed that if you ask the patient, do you have hay fever, that actually is the best question you can ask. It changes the pretest into a post-test probability the best. Probably the least effective question is nasal symptoms. Do you have sneezing and runny nose? Doesn't really help you that much, mainly because so many other conditions have the same symptoms. And if you do a skin test, you can see that the likelihood ratios for a positive skin test are pretty good. And a negative skin test, it means that the probability goes down quite a bit. So intracutaneous test or intradermal test, the performance is not quite as good. Look at grass pollen, it barely changes at all. There's no reason to do it for grass. For cat and mold, maybe there's a better reason to do it. It seems to be dependent on which allergen you're looking at. And if you look at the blood tests, again, the blood tests are very good at identifying patients who do have an increased risk and also at decreasing the probability in those who don't have a risk. And in fact, this is a study that was done by Hugh Sampson based on the COFAR data. It's a giant database of food allergy patients. And it looked at likelihood ratios for skin test, IgE, and ARA-H1, 2, and 3. I point out that the LR minus is incorrect because the negative likelihood LR minus has to be less than 1. It's likelihood ratio if the patient had a negative test. It's got to decrease it, and so that has to be less than 1. This is a misprint in the text. Here's the actual values. If a skin test has a sensitivity of 96% and specificity of 73%, the likelihood ratio is 3.5. Negative likelihood ratio is 0.06. And the same for specific IgE and for all the ARA-H1, 2, and 3. If you have an ARA-H2, given a positive specific IgE, let's say the IgE test is positive, the likelihood ratio is only 1.59, which isn't that great. But if you then do the ARA-H2 afterwards, now it increases it to 4.65, and that's a really good likelihood ratio. And that performance is actually superior to the performance of a skin prick test, which has a likelihood ratio of 3.53. So you can actually compare the performance of each of these tests looking at the likelihood ratio. So you do a test if the potential results have a reasonable likelihood of changing or confirming the decision. If the treatment will not change regardless of the test results, don't do the test. So if we're looking at probability of allergic rhinitis, if it's very low, treatment, the patient, you're only trying to determine this in somebody with nasal dysfunction. If the probability of allergic rhinitis is low, then you treat them with medications or surgery. If it's very high, then you could recommend allergy shots and environmental control, which treat allergies. Or if it's in between and you're not really sure, then allergy tests may help to try to figure out whether they really have allergies or not. And how do you decide what treatment to recommend? Again, we're back to our model, the probability of disease. It goes from 0 to 100%. And what we're trying to do is to maximize wellness, sometimes called utility. How well is the patient? What we want is the patient to be 100% well and not at all sick. And so if we don't treat the patient and they don't have the disease, the probability is 0%, then they're totally well. But if we do treat them, if we don't treat them and they do have the disease, then their wellness decreases by amount equal to the disease burden. How much does the disease make them feel bad? That's how much their wellness decreases if we don't treat them. If we do treat the patient and they don't have the disease, then the treatment might cause harm. The burden of treatment, there might be side effects from the treatment, just the cost of buying the treatment. That's the harm from the treatment. That's how much the wellness is diminished by treating someone who doesn't have a disease. If they do have the disease and you treat them, presumably they get benefit from it and their wellness increases. So that's the treatment benefit. What we're looking for is this treatment threshold above which the treatment helps and below which no treatment helps. And that's how you can decide whether to treat or to not treat for a specific thing if you know what the treatment threshold is. So if you have the disease probability and it's below the threshold, the strategy is don't treat because they're likely not to benefit from it. On the other hand, if they do have the disease or have a high probability of having the disease, then the strategy is to treat because that maximizes your wellness. And so you can use this treatment threshold to determine whether to treat or not to treat. Remember, tests for allergy identify the presence of specific IgE. This is called sensitization. It is necessary but not sufficient for an allergic response to occur. Many sensitized people can be exposed and not have symptoms. The amount of specific IgE gives you evidence that can be used to determine the probability that there will be an allergic response to exposure, but there's no guarantee. This is one of my pet peeves. If you do an allergy test, on the lower left, you can see the results of the allergy test. It gives you the results, and then it tells you the reference range. And then there's usually a flag on the far side, on the right side, that says abnormal if it's above the reference range or outside of the reference range. You notice that soy and wheat are not outside of the reference range, so they're not abnormal. A lot of doctors will take these abnormal or little capital H's, maybe it's in red like shown above, and they will circle that and tell the patient, well, so you're allergic to peanut, look at this, and they circle it. It's the red circle phenomenon. The problem is it's the frequentist approach. It's not taking into account the probability, the pre-test and post-test probability that the patient actually has the disease. It's just circling lab values. It's not even looking at positive predicted values, so it's kind of worthless. I don't find having these numbers just by themselves to be very helpful in helping to determine whether the patient should be given an EpiPen and told to avoid eating peanut. My preference is to use what's on the right side. So here we have the peanut, we have these different results, and we have the results. And then instead of showing a reference range and a flag, we're given the likelihood ratio for having a systemic reaction. In this case, if the peanut IgE is 7.8, the likelihood ratio is 18.8. So using the McGee heuristic, you can then determine how much higher the probability is that the patient is going to have a reaction to peanut than it would have been before you did the test based on the prevalence of the peanut allergy. And so you can use likelihood ratios to make these calculations if only the labs would provide them to us, which none of them do. We can start demanding it, insisting that labs, maybe picketing them, boycotting them. I don't know what you can do, but we need to let them know that we want likelihood ratios so that we can better interpret the test results. Okay, allergy extracts. Here's a typical example. A pharmaceutical rep from an extract company is coming in to promote their latest ragweed extract. And they tell you that this is the greatest extract in the world. If you test for your patients with it, they will be positive and you'll be able to put them on allergy shots because that's what they think allergists want. I ask the following questions. How likely is a patient with the given wheal or erythema size to have symptoms if they're exposed to ragweed? How likely are they to not have symptoms? In other words, what's the likelihood ratio for each wheal and flare size? What is the likelihood for the various values of the skin test? What is the sensitivity, specificity, positive and negative predictive value for the test? And what was the prevalence of ragweed allergy in the population that these values were determined from, the population studied? You can ask the rep these questions. That person's eyes will glaze over. They have no idea what you're talking about. They absolutely will not be able to answer the questions. If they call the company and ask the scientists who did the studies, those scientists won't know either because this information is usually not determined, and that's a problem. We need to start demanding better information about the extracts that we use in our skin testing. This doesn't necessarily have to be a new extract. We've got a whole bunch of extracts that we use, and we have no idea what their performance characteristics are. We really need to push the companies to make that determination. That's the research they should really be doing. Okay, this is a really busy slide. I hate to go through it all, but I think it gives a lot of really good information. This is how we can use the Bayesian approach to determine the probability that a patient has food allergy. So in the upper left-hand corner, if we don't know anything about the patient, then the probability that they have peanut allergy is 1.4%, let's say. So we have to convert it to odds, 0.014. And then if there may be differences in the geography, if it's done in the United States versus elsewhere, I'm not taking that into account. And you might also want to know whether they ate the food and what kind of reaction they had. In this case, they never ate the food, so the likelihood ratio is 1. That doesn't help. Specific IgE of 10.4 gives a likelihood ratio of 6.1, so now the running odds is 0.087. We're not going to do skin test, component IgE, or epitope IgE, although we could do component IgE. And so the final probability is 7.97, almost 8% probability. It started out as 1.4, now it's 8%. We still have to figure out what to recommend to the patient, but at least we can tell them what the probability is if they eat a food that they're going to have a reaction. If we look at the graph on the bottom left, it's pretty much the same information. They never ate the food, and yet the IgE is 10.4. And now we're doing the reflex test, the ARA-H2 of 5.23. It's got a likelihood ratio of 25. By using the components, our final probability estimate is now 68%. And I think all of us would have no problem recommending avoidance and carrying epinephrine with a 68% probability of a reaction. So doing the component clearly helps. If we didn't do the component, the ARA-H2, it was only 8%. If we did it, it's 68%. It just makes it much clearer what the recommendation needs to be to add this piece of information. On the right-hand side, we've got a patient who ate peanut and had no reaction. So we know that the likelihood ratio is very low. The running odds is very low because the patient ate peanut and did not react. Let's say his IgE is 10.4 and his ARA-H2 is at 5.23. These are all very high, so he's got all these false positive tests, and yet he's really not allergic to the peanut. If we look at the running odds, final odd is still 0.002. Final probability is 0.22%. So even though these tests are positive, our estimate is still very low. The Bayesian approach doesn't mislead us. It tells us accurate information as long as we take into account the pretest probability. And finally, if we have a patient who has anaphylaxis, they ate peanut and immediately had anaphylaxis, their odds are really high. Let's say the specific IgE is less than 0.1, so the test is negative. The likelihood ratio for a negative test is 0.21. That lowers our odds to 0.298, but there's still a 23% probability that the patient will have a reaction. That's high enough that most of us would still recommend avoiding the food and carrying epinephrine. And so you can see how with a false positive and false negative test, which is what's shown on the right, you still get the right answer as long as you use the Bayesian approach and not the frequentist approach. What do we really want to know, though? Is the patient allergic to a particular allergen, the diagnosis? Well, the presence of specific IgE suggests that maybe they are. If there's no symptoms, the answer is no, and if there are symptoms, the answer is yes. For foods, we're actually asking a different question. I don't want to know, is the patient allergic to the food? What I want to know is it safe to eat the food? That's the treatment. You can have a mild reaction like itchy mouth and oral allergy syndrome, hives, pruritus, even sneezing, and yet you're not having a life-threatening reaction. It may still be safe to eat the food. None of these are dangerous or life-threatening. The food can safely be eaten even if the patient's allergic to it, as long as their symptoms are not life-threatening. We don't really want the diagnosis, therefore. What we want to know is what to do with the patient, how to manage them. Part of the problem we have is our estimate of, we're not very good at determining how likely events are for different probabilities. Here's a variety of different probabilities. So for example, the likelihood that you will end up in an emergency room due to an injury is 1 in 10. So 1 out of 10 people in any given year are likely to show up in an emergency room due to an injury. Death from any cause in the United States and Europe is a 1 in 100. So there's a 1% probability of dying from any cause. Death due to murder in the United States, 1 in 10,000. And then if you look at the fatal food anaphylaxis in patients who are diagnosed with food allergy, it's about 1 in 1 million. It's very improbable that, If a patient has a diagnosis of food allergy, they're very unlikely to die from it. It just doesn't happen very often at all. You're far more likely to die from being murdered in the United States from food than from food anaphylaxis. That's why I've jokingly said maybe we should give our patients bulletproof vests instead of EpiPens. They'd be safer. That's not serious, but it certainly makes sense given this information. Lightning strikes, by the way, are 1 in 10 million. So here are the two diagnosis scenarios that I'm proposing. And this thing is a neural network. A neural network is a machine learning tool that can be used to take inputs, which are called features, do an analysis using input layers, hidden layers, and output layers. I'll talk more detail about this when I talk about artificial intelligence. And the output is a series of diagnoses, and it's a probability of having different diagnoses. So DX 1, 2, 3, and 4 gives you the probability that each of these diagnoses is present given all of the input features. The problem is, given a particular diagnosis, you still have to figure out what treatment is likely to be beneficial. And each diagnosis may be associated with a series of different treatments. Each of them have a different probability of being beneficial. So it becomes very complex. That's the diagnostic treatment model. My preference instead is to go directly to treatment. You take the features and you ask what treatment is likely to help a patient with these features. I don't care what the diagnosis is. If you do that, then you get a likelihood of a treatment benefit, but there's only 4 of them, and you can just choose the most likely thing to benefit and just skip the diagnosis part. I know we love diagnosing things, we love calling things a certain thing, and patients want to know the name of the disease they have, but that's not really what we want to know. We really want to know what to do about it, and by going directly to likelihood of treatment benefit, we're better off because we know what treatment is likely to help regardless of what the diagnosis is. It might be a disease that doesn't have a name, but the treatment is still more likely to work for that particular constellation of features. This is a future thing. It's not something that we currently use, but it would be really nice when this comes about. So I'm just going to finish up by talking about different approaches to computer-assisted diagnosis and treatment, because this is the future. This is where we're headed. Currently, we use logistic regression. It's the frequentist approach. It's basically a linear combination of features, dichotomous classification. The test is positive or negative. If you get new information, you can update the model. It's difficult to evaluate for nonlinear feature contributions, but it does provide insight regarding the outcome. It tells you which features contribute how much to the diagnosis, so you can understand how the features interact with each other. The Bayesian network updates priors using feature likelihood ratios. It's kind of like what we've been describing today. You can look at the number of independent features and the performance of their likelihood ratios, but using those you can update with new data, and then it does provide insight into how the outcome was obtained. And then this neural network is a nonlinear approach. This is the thing here where each of these little circles is a neuron, and there's an input layer, hidden layers, and then an output layer. There's really no assumption regarding input features. They can be linear, nonlinear, they can be text, pictures, sound, anything you want. It accounts for all of these features. There's almost an unlimited classification output is possible. It's difficult to update the model with new data. Basically, you have to retrain the whole model with the new data. It requires large training sets to improve reliability, and it's kind of a black box because you really have no idea what's going on inside. You put the features in and you get the output out, and you have no idea how it came up with that idea, but most of the time it can be correct. So I'm going to conclude here. Just with a few thoughts. The level of IgE does not indicate the probability of disease. It indicates how much more or less likely a diagnosis is given the results. That's all the IgE does. It doesn't tell you the probability. Components and possibly epitopes measure something different than total IgE or allergen-specific IgE. they provide a differential, the same way that a CBC supplements the total white blood count. Just saying the white count is this is one thing, but if you want to know what kinds of cells, that's what components tell you. The purpose of a diagnosis is to give the condition a name. That's the only reason we make a diagnosis. It also may help to estimate how effective various treatments are likely to be, which is what we really want to know to begin with. But they can be misleading if you use loosely, i.e. food allergy is what we usually talk about. What we really want to know is it safe to eat the food? And that's different than food allergy, simply because you can have food allergy and it may still be safe to eat the food. And newer models are being developed that will lead to computer-assisted diagnosis and treatment, which I'll be talking about next week. So again, practice takeaways. Diagnostic tests are used to update your pre-test credence of the diagnosis to a post-test. Likelihood ratio can be used to determine how much more or less probable that a diagnosis is than you thought it was before doing the test. The reflex test is used when a primary test is indeterminate and you want additional information. Our lab at Children's Mercy does do reflex tests. We call them algorithms, but that's what they are. And component testing can help to determine more details about sensitization. And with that, I'm going to stop. I know